AudioJungle.
Let's just start with the kind of Daniel Kraft question, which is the sort of big picture, and then we'll talk more specifically about the cancer therapies that you're working on. But you talk on your website of your company about how we're entering a cognitive age. And I wondered what you think that is, and what does that mean for cancer?
You know, the reason we raise this issue on cognitive age is because we came to realize very early on, around 2006, as we begin to evolve the knowledge through molecular medicine. And when I use the word molecular, I do not mean genomics. I actually mean proteomic, because what we're really trying to understand is what drives the cell. It's not the gene, it's a protein downstream. So think about this. There's 3 billion base pairs controlling 20,000 genes, controlling 200,000 RNA, controlling maybe 1 million proteins and 10,000 pathways to find the pathway. That is the cognitive overload that would be impossible for any human being to figure out in real time before you start treatment. So I asked a very simple question. Wouldn't you want for your loved one to know quantitatively the treatment that should be given to the patient before treatment begins? A very simple question, before treatment begins. And that cognitive overload, unless we take into consideration the capacity now of cloud computing, supercomputing, artificial intelligence, machine learning, and validated science down to the biological level for a practicing community oncologist to give the right treatment before treatment begins, is something this planet is not prepared for. And that is what we decided we want to go after.
So what I found interesting about you is that you also said, and guess what, we've done it, which was the real shocker for me. So, because most of the people who've been talking today have talked about this problem and how we're going to overcome it, but you've actually been kind of working on this. And I wonder if you could talk to me a little bit about what you mean by next generation immunotherapies and how this fits in with this cognitive age.
And most people come to the conclusion that somehow we've sort of done this and it's only taken us a year. I've been at this since I left medical school. I came to this country, well, not this country, I'm not sure where I am, I'm in the United States, I'm not in England. So I came to the United States and I heard this morning about the R01 grant. So I was lucky enough to have an R01 grant, a VA Merit Review grant, very early on in my career, and got funded by NASA. Not many people didn't realize I got funded by NASA and NIST to develop stem cells for astronauts on Mars. So I was part of the shuttle program. So this concept of artificial intelligence and machine learning stem cells immunotherapy emanated from the early 1990s. My first paper on the natural killer cell was in 1990. What came through that evolution of thought was that all of us have within our bodies a God-given protection, whether it be stem cells. We have circulating stem cells that are there to actually protect us, and we have natural killer cells that are there to actually kill infected cells, viral infected cells, and cancer cells. I think it would be a scary thought for people to realize that as you're sitting here, you're generating probably 10,000 cancer cells a day in your body. And the only reason you don't have cancer is because your natural killer cells are recognizing stress cells and infected cells. And this thing called innate immunity is active. So my lifetime challenge was to figure out how do we take the biological system that is innately and inherently in your body and been given through evolution and actually utilize that in the practice of medicine. And I realized also that nobody's thought about this as a systems approach. I mean, you listen today, wonderful speakers, and it's all siloed, episodic issues. But if you think of a system, then you start getting overwhelmed by the need of this information exchange. And the first thing I needed to fight on was interoperability. But people confuse that as if I'm trying to sell an electronic medical record. It had nothing to do with electronic medical record. It had to create a fluidity of data across the system. So I spent a huge amount of my effort doing that. And today we launched all of Toronto, all of the VA, all of Chicago, lots in Chicago. The entire VA has this interoperable system and can talk to anybody at the DoD. So we have an interoperability system. But the next challenge was, how would you actually move this kind of data around? People don't realize that every time you do a sequence, you're talking about a terabyte of data. So if we're trying to talk about 13 million cancer survivors, that's at least 2,000 to 3,000 patients a day, who's going to move 2,000 terabytes of data around into a supercomputer that doesn't exist? So I took over the National Lambda Rail, which is a Large Hadron Collider running that, and surmised that what we are doing, when you think about what we're trying to solve, the Large Hadron Collider was looking at collisions of two atoms. We actually have collisions of proteins in our body every day. Some are mutated, some are not. And our job is to go find those collisions every day, which means you needed to create a fiber infrastructure that could accommodate that. So we've built that. The next thing we need to do is go build a supercomputer that could analyze whole genome sequencing to tumor normal, to the transcriptome, take the pathways to find the actual protein pathway. We built that since 2003 to 5. It is the basis of the 6 Nature papers from the TCGA. It's the basis that discovered the FOXM1 pathway was equal between serous ovarian cancer and triple-negative breast cancer. The next question was, how would you then actually, I'm a surgeon, there's no way you're going to inform surgeons to go after frozen sections. Could we harvest archivally all the paraffin sections? And nobody believed you could do that. And NIST was one of them and funded an organization in Rockville, right next to the NCI. We funded that organization. And I'll share with you today some news, very exciting news. We can now quantitatively measure the proteins from paraffin sections. And in fact, I'll break some news today, a paper will be published which will show that we can quantitatively measure HER2. And if you're a certain cutoff level of HER2 and you take single agent Herceptin, you have a 5-year survival of 95%. But if you're a different level of same IH3 positive HER2, a different level cutoff level, which you'll see in the paper, 50% relapse within 1 year. We can now predictively, quantitatively predict based on quantitative proteomics. So this evolution from whole genome sequencing to proteomics to supercomputing to machine learning has been a path which then leads us to what do we do with this? Well, it leads us to now adopt the immune system. And that's what we'll get into in terms of what I consider next generation immunotherapy.
Can I just stop you a second? I will, if you do want to ask questions, there will be some time later on, and please also you can use the app as well. But do go on, let's go on and talk about immunotherapy.
So if you look at immunotherapy and you look at all these checkpoint inhibitors, as I said, there'll be commodities, PD-1, PD-L1, CTLA-4, TIM-3. And what that is the right thing, because I spent all my life trying to break tolerance to induce tolerance when I was doing islet cell transplant or transplant. What cancer is all about is, in fact, the reason you get cancer is because your natural killer cells, or your T cells, stop recognizing this cancer cell, and in fact, the cancer's induced tolerance. So the whole idea from a systems approach is to break tolerance. But by that, you mean actually induce the system. There's 2 kinds of cells in your body. One called a T helper Reg cell, which actually suppresses, and the other one called a killer cell, which actually induces a T1 immunity. So if you think about that, there's 3 types of immunity in your body. One called adaptive immunity, in which your dendritic cells. So when you get a flu vaccine, it activates these dendritic cells, it induces memory, and when you get flu, it's going to treat you. That's activation of dendritic cell, and that's the vaccine. The next thing that happens, that really does happen, is that your body has these innate cells called the natural killer cells that locks onto a cell that is stressed or infected, kills it with bullets called perforin and granzyme, explodes it. And as it explodes it brings in the adaptive T cells. But now you have to actually block these T cells to push them to the right path, to the killer side rather than the suppressor side. And that's where the checkpoint inhibitors. My concern is you're going down the siloed approach again, just taking a checkpoint here and a checkpoint there. And if you can now activate the dendritic cell, activate the natural killer cell, activate the checkpoint inhibitors appropriately, and activate the microenvironment of oxygenation within that environment, you have a comprehensive approach to immunotherapy. And then take chemotherapy based on our targeted proteomics and analyze the resistance factors based on that particular patient that's resistant to Taxol, cisplatin, carboplatin, and treat chemotherapy like antibiotics. But now, give chemotherapy not at the maximum tolerated dose, but at the lowest effective dose, and cause what I call cytostress, not cytotoxicity, to stress the cell, to activate a receptor on the stress cell called NKG2D that is reactive to this natural killer cell that'll kill it and then bring on your T cells. That sounds completely logical, except that is not at all what we're doing today for patients. We're doing completely the opposite. We've been taught, and this is the pain now, the pain of dogma, based on assumptions that has now dogged us for 40 to 50 years. 1, cancer is a clonal disease. 2, those cancer cells proliferate linearly. So therefore, if that's the case, and by the way, these are just few papers. I mean, it was a mathematical paper. Therefore, if that's the case, let's give everybody a maximum tolerated dose in the hopes that we will nuke this clonal disease. So we've been giving patients a maximum tolerated dose. What we've been doing is wiping out the immune system. Yet cancer is not a clonal disease, it's multiclonal, which means actually all you're doing is you're actually waking the cells that are asleep and pushing yourself down the pathway of inevitable recurrence. Inevitable recurrence. And then because of heterogeneity, targeted therapy is actually in its own right useless because it's going to find another pathway. You have another level of inevitable recurrence, which means then we're doomed unless you really realize that we're not doomed because we have our own self-protection mechanism, which is to stress the cell with chemotherapy, with low-dose radiotherapy, induce dendritic cell activation, give the natural killer cell, and then go after the stem cell. Now, talking about the stem cell is a cell that doesn't divide. Yet we've been building chemotherapy for cells that divide. So for 40 years, we've been giving drugs for cells that don't matter. So there's just no way we're going to get to that stem cell. So then when you get to that stem cell, we look at the metabolic nature of that cell, look at the factors that cause cell differentiation, and now we have a chance for cure. So that's the pathway that we're pursuing. I can show you a few slides, maybe 3 or 4 slides to explain that. So this is your natural killer cell that is in your body, that you and I have, and it'll see the disease cell, and if you could play that video, and that's what's happening, the perforin and granzymes. So these are the bullets that you are armed with, that you're born with. That cell is 300 million years old. It's from the Cambrian age. It's from evolution. It's the only way in which vertebrates could survive. That natural killer cell, by the way, when you think about it, is what actually is part of pregnancy. Because think about the allogeneic transplant that you have with the mother and the father. And that natural killer cell is actually and so look what it's done. It's exploded that cell, and that's what's protecting you every day. We're wiping out that cell with maximum tolerated dose chemotherapy. On the other hand, next slide, this is what you're faced with. These are what I call the dance of proteins that's in your human body that's keeping a cell alive that somehow gets mutated. One level of mutation, next slide, is that. That's just what I call an EGFR or HER2, and it goes all the way down. We can now predict the cutoff level of that HER2 proteomically in real time today, and that paper will be published, that will define whether you are one of those patients, if you're on Herceptin, in the adjuvant setting or the metastatic setting, will have a 5-year survival of 95%. Why aren't we doing that? We have now an ability to measure the alpha-folate receptor. We'll predict that if you take this particular drug and you have lung cancer with the alpha-folate receptor, you will have a 5-year survival of over 80%. We can predict that if you have triple-negative breast cancer, you have the capacity now to express an androgen receptor, and we can give you a prostate cancer drug. So, but if you look at that dance of proteins and you see the peripatetic efforts that we must make, which I'm not saying we shouldn't make, but these are all forms of factors of drugs that's being developed right now. This is what you call the pipeline. And if you think of the Indiana Jones movie where you try and shoot all these knives, and somebody with a gun and just shoot you with a bullet, well, that's what we want to do with natural killer cells. Because you can go after the entire pipeline, or you can take out and target. So this is the very first demonstration ever. We've never shown this before, in which we've taken that natural killer cell and we've added Herceptin to this breast cancer cell, that's a HER2 positive breast cancer cell. And now this natural killer cell, together with that HER2 antibody, and if you see, hopefully this video is running, it is, watch that cell and watch the bullets now going into that cell. And this is a human breast cancer cell exploding. That is the bullet, the Indiana Jones movie that we're going to actually do, and that's going now into phase 2 clinical trials. But we can, even more excitingly, target this natural killer cell. So we have now discovered a method of actually identifying neoepitopes. What do you mean by a neoepitope? It means that every human being, there's thousands, now hundreds of thousands of mutations. And every human being has a different form of mutation in their own cancer. And these peptides are unique even to that same human being. That means if we could take those peptides and put it into an adenoviral vector, our vaccine, which now will go into phase 2 and phase 3 clinical trials, and we can activate the dendritic cells, we can actually create your own vaccine. Or you can put it into these NK cells and then target that to the cancer. This happens to be a HER2 positive, the red, and HER2 negative, normal. And that NK cell has on its surface a HER2 targeting. So it'll home, it's not touching the normal cells, and it is destroying the targeted cell. And if you look at the ability of this to destroy completely, which then says we're now at the final stage where we can, for the first time, cross this chasm. When I mean crossing the chasm, we can take a patient and instead of focusing just on the tissue, i.e. the anatomy, cross into the cell, look at the checkpoint inhibitors, cross into the DNA, look at the entire genome, cross into the RNA, look at the prior protein, cross into the peptide, look at the peptide screen, and do what we call cellular molecular biology, integrate that with the clinical EMR databases, and then drive 21st century medicine. We've got this current state where we have these HIEs and static databases, which are meaningless, tied to EMR systems that don't talk to each other, tied to specialists that look upon breast cancer and lung cancer as if they're different, and actually not integrating into this whole dynamic change that's happening along. What I'm excited about is we're launching this throughout the nation. We're starting with Tufts, and Tufts is in the room. We're starting with Oxford, we're starting with Phoenix Children's Hospital, we're starting at UCLA, we're starting with hospitals in Canada, but most importantly, and Carla's in the room, we're starting with the community oncologists, because that's where cancer care is given, so that we're going to integrate this on this country and create what we call IM N=1. So we're going to launch IM =N=1, in which it'll be the largest bundled trial, we call it the bushel trial, and in which we'll place all these mechanisms in which it is a process as opposed to a drug to drive cancer into remission, prolonged remission, so we can drive it to the stem cell. We're not going to ignore pediatrics. We're going to call that the bassinet trial, and we're going to do the same with Phoenix Children's and with Tufts and together with Sick Kids in Toronto. And I'm excited to say that is now in motion. And I'm in discussions with pharma, discussion with payers, and discussions with the providers to establish an educational system. I think most importantly, we're going to end up being in discussions with patients so that they could be empowered to know about this.
What are you going to tell patients, and how many, what are you going to tell patients about what you're doing? Because obviously you can't have this conversation with every single one. And well, let's just start with that one, for example. And how many of them are there going to be in this trial? How many can you handle?
Well, so that's going to be, I'm in discussions with the FDA, I'm in discussions with pharma, Amgen has brought their drugs into the fold, Celgene's bringing their drugs in the fold, Glaxo will bring their drugs in the fold, Biotech will bring drugs into the fold, and it'll be the largest, access of drugs. And I'm even bringing generic drugs, Taxol, cisplatin, carboplatin. I'm speaking to Fresenius, my old company, where we can target the chemotherapeutics. And then we're going to bring, because we're in this world of siloed, we'll create pancreas cancer, lung cancer, breast cancer, myeloma, so that, and we just launched our first Merkel cell carcinoma, HPV, viruses, induced cancer. And we'll just create the list and then we'll have to do standard of care, that's what I asked, versus a combination. And we agnostic to the combination, because what will drive that combination will be the evidence. And the evidence won't be some 20 panel, 200 gene panel. The evidence will be 3 billion base pairs times 20,000 genes times 200,000 RNA times the proteins, so that we can actually validate. And then at the end of the day, the truth of the matter is going to be the outcome. And until we can actually monitor that outcome, and then we can monitor on this global scale, because there'll be no capacity of any one single organization, even one country, to capture enough data, because every cancer is a rare disease to itself, to that patient. So that 3 to 5 years from now, we can validate it. I'm glad to say we already have 18 petabytes of a database. We have a system now that it is our obligation to have that shared. I heard about this program at the CEO Council today and the CEO Roundtable. So what we're going to tell the patient ultimately is get educated. If you have cancer and your loved one have cancer, think of yourself like an HIV patient. Let me give you this level of education. Because we quietly been saying some of the things. I got a call from Ivor Royston, a doctor, a good friend of mine, who says, listen, my friend has a patient with cervical cancer and 6th round of chemotherapy, and she's dying. They're saying goodbye to her. Will you do a genome sequencing? I said, absolutely, send it. She had an HPV virus inserted into her genome, which overexpressed ERB2. She needed Herceptin. We called. They lied to the insurance company, said she had breast cancer, gave her Herceptin, she had a complete recovery, went on a cruise for a year. This is a cervical cancer patient. We had a brain cancer patient, a young boy at UCLA just 6 months ago now. Had a brain tumor removed, 17 years old, felt the next step was, because there was a residual brain tumor, he had to have radiation. They were so scared because it was going to wipe out his brain. We did the whole genome sequencing. We had to argue, this is at UCLA, not to do just the panel. We found he had a very strange aberration, which is an off-target use of Gleevec could actually treat this boy, and it did. So we had a patient from San Francisco who, again, was thought to have pancreatic cancer. Lady, failed all therapy, did a sequence. In fact, she had ovarian cancer, gave her carboplatin, which is the basis of a drug. She had a fantastic recovery. So we are seeing these now These are perceived as anecdotes. We're just seeing patients that are alive. Some of you may have seen the 60 Minutes piece, and I'll say that because this patient made himself public. His name is David Roy. He was told by a local hospital in Los Angeles to go home. He has 2 months. He's going to be in gemcitabine. Don't take the gemcitabine. He has 2 months. I knew David for 20 years ago. He found me. We did a whole genome sequencing. Put him on the treatment that I've just been telling you about, low-dose chemotherapy, a dosage of Abraxane that is not the dose that is currently approved dose. And he is alive today, 3 years.
This is pancreatic cancer.
Metastatic pancreatic cancer. We have our first patient with metastatic pancreatic cancer that we put this patient on. She's alive today, 8 years. My cousin had metastatic pancreatic cancer. She was in Toronto. They were told to do exactly that. I said, no, come down to LA. We kept her alive, unfortunately, for 1.5 years, and then unfortunately she had an embolus. Didn't die from cancer, she had a thrombotic embolus. So what I'm telling you is very painful because we see the outcome of it. We need to figure out a way to scale this.
Yeah.
And so that's why I'm asking people like Tufts and people like UCLA, but also the community to educate this. And so we need to go to the mobile platform. So that's why you sort of see...
What platform?
The mobile platform.
The mobile platform.
So we've put out an app out there. It's in beta called Cancer Connect. I just met somebody today who has another app and who is actually going to use that app to educate doctors. We created the Cancer Genome Browser, and you've seen me with BlackBerry and John Chen, where we can actually, you could browse to your single base pair in real time through the cloud, so that you could either have the information at the most sophisticated level, or you can have the information at the lay level. But I think what's going to happen is that the patient will finally catch up and drive this change.
Yes.
And I think that's what's going to happen.
I don't want to hog Patrick. Is there anyone who has any questions in the audience, who has any burning questions to ask in the last few minutes? Okay, well, I shall take my speaker's prerogative a little further then. I mean, of course, this is all incredible, but of course the challenge of the whole N=1 thing is how do you validate this approach and how do you get the FDA to approve it, right? And so, yeah, I mean, can you just talk me through a little bit about how that's going to work?
So Senator Frist and I established the CEO Council at the Bipartisan Policy Center to participate in the FDA Modernization Act. So I'm pleased to say we released the report, and working with Senator Lamar Alexander to create language for the FDA to be modernized in this whole new world. I think what was said that the FDA is not the roadblock is completely true. I've worked with the FDA now for 10 years of my life. Given the opportunity, and that's very important, given the opportunity to collaborate, they jump at that. So I was just on the conversation with the FDA just last week because we're about to launch this vaccine, the CEA vaccine, in which we've already done 32 patients with colorectal cancer that failed 3 to 4 different levels of chemotherapy, and administered this vaccine in 32 patients, a vaccine under the skin based on CEA that induced dendritic cells, and we have 12-month survival. I got on the phone with the FDA and said, listen, we need to expand this, and by the way, I have a new epitope for my cancer patient with pancreatic cancer. And not only they immediately allowed us to go into that expanded, but they invited me immediately to provide a protocol for the new epitope vaccine. Think about that. That means a clinical trial for everybody, every single patient. And they're struggling with that, but they're open to it. So we need to help this, what you call this coming full circle, this next generation immunotherapy. Because we need to now completely rethink what we've been doing, that chemotherapy should be targeted chemotherapy, proteomic therapy should be really targeted proteomics with the full knowledge that that target is unleashing other targets. Therefore, you need to simultaneously unleash the dendritic cell, you need to unleash the T cell, and you need to unleash the natural killer cell. and you need to unleash the metabolic environment around that tumor cell to increase oxygenation. So if you do all of that, I think, and you show survival, which is at the end of the day the golden, or progression-free survival, or actually truly a bearable system where the patient could have a quality of life. David Roy plays basketball today. He played basketball with us. So that you have a quality of life that makes cancer a bearable disease and a chronic disease until you wipe it out. I think we'll get there with the FDA. I don't think FDA is going to be a concern, in my opinion, at least at this point. I may be Pollyannish, but I don't think so.
Do you have any concerns then?
Well, I always do have concerns because, you heard the question I asked this morning and the pain that I had, I went through personally in designing, and I designed the trial for the breast cancer, approval for Braxane, I designed the trial for lung cancer, and designed a trial for pancreatic cancer, knowing that it was the wrong design. But it was the only way then, at that point in time, for me to get this done. Think about the trial I had to do for pancreatic cancer, single arm gemcitabine on the one hand, and then gemcitabine, which I think had no effect, plus Abraxane on the other hand, at a dose of Abraxane I think was wrong. So what we ended up with was a 2-month survival benefit, which according to everybody was the most advanced in 20 years. Yet, behind the scenes, I've quietly done trials in 50 patients in which I didn't use gemcitabine. I used drugs that actually cause immunostimulatory and Braxane at the very lowest dose, and I've got a median survival of 24 months. So what do I do about that? That's anecdote. That's not even published. So the idea now is for me to go, and that's the beauty and the joy of this whole fervor of immunotherapy. I think this fervor of immunotherapy, of the CD19 approach, the CAR-T approach, the checkpoint inhibitors, has opened up the path for us to actually evoke this change. Because you need to do these combinations. And so when I asked this morning about, the only question I've asked in this entire symposium is, what are you going to do about the combinations? It's not combinations for the sake of combinations. It's the sake of actually looking at now a process where you may use a Merck drug, AstraZeneca drug, a Pfizer drug with a generic drug, and you get survival. What are you going to do with that?
Give it to patients, hopefully. I just wanted to ask one kind of like left field question as we wrap up, but it seems to me the logical implication of what you're saying is that all the organ-based patient advocacy groups, ovarian cancer, breast cancer, liver cancer, really just need to get in the room together and just start advocating for what you're saying, sequencing, finding out proteomics, finding out the molecular basis for their cancers, because this is still very expensive, right?
Right.
And, that seems to me to be the logical conclusion. Would you agree? I don't know if you agree.
Completely agree. Well, I'll just be now coming down to the pragmatic practicalities of it, right? So we call this test GPS, which is genome proteome seq. We use that word GPS because it's the molecular address of your cancer. Realistically, it costs about $30,000 to do. From a time-wise, by the way, from the time we get the biopsy to the time you get the report is 7 days. We can do that in 7 days. If you gave us the informatics, you did the sequencing, let's say, and you gave us the informatics, just the raw data that comes out of the Illumina machine, we can do 2,000 a day, 2,000 bioinformatics analysis a day. So it's all doable now. Now the next question is, how do you address this cost? We personally, and that's where now the philanthropy comes in, and our own family foundation have committed to actually commit $1 billion to support subsidizing this. But it doesn't go a long way when you have to do the math, when it costs $30,000 per patient. So the idea is to figure out how you actually bring collective philanthropy into a room. And then you tie pharma to this, and collective pharma, because from pharma perspective, if they could actually identify the molecular address, you'd actually have a real chance of getting a great outcome. So you're absolutely right. The idea is treat the biology, not the anatomy. The idea is not just think of genomics, but go all the way down to proteomics. And the idea is it's N=1, where the clinical trial, the clinical practice, and the basic science is a complete blur. It must be a blur in order for us to advance.